Hello students, this is my presentation on kidney transplantation and um, and if any other notes I give in class, then it will be inclusive of this odd topic. So let's go to the next slide. Um, More than 93,000 patients are currently awaiting kidney transplants, and I think most of you are aware of it. And fewer than 25% ever receive in that kidney which they have been waiting for. And the transplantation from a deceased donor, like a cadaver, usually requires a prolonged waiting period, and differences in waiting time will depend on age, gender, and race. Average wait time in US for a cadaver kidney is approximately 2 to 5 years. And and as I was saying, that it also depends on age, gender, and race. So, and it might happen if there are two candidates for that kidney, and the first candidate is a 10-year-old girl, and the second candidate is a 55-year-old man. Uh, they will see, you know, a lot of factors behind it, and they will prefer giving maybe the kidney uh, to 10-year-old girl than a 54-year-old man. Who so it's they have to look certain things, the life expectancy, how much compliant the patient has been with their, you know, mm, regimen, with their diet, medication regimens, all these are looked into if the patient receives any kidney. And because of the such a long wait, medical tourism is becoming very popular. Many patients, they go out of the country to get the kidney transplant done. Next, go to the next slide. Now, kidney transplantation is very successful if it's done, and the 1 year graft survival rate for cadaver is 90%, and for live donors it's 95%. And when I'm saying graft means the transplanted organ. And the how the if they will follow the patient from the time they get the transplantation to the, you know if to the date, if there has been a rejection by the body of that graft. So they will keep on following the patient. So they will look at the patient's survival after that graft, and they will also look at the survival of the graft separately. So did the patient survive on the basis of this transplantation, or the patient is there, I mean he's living, but the graft was rejected by the body and patient has gone back to dialysis. So there it will be a complete follow-up for that. Let's go to the next slide. Advantages of kidney transplantation over dialysis. This is quite self-explanatory. You can see that it reverses many of the pathophysiological changes which are associated with renal failure if the patient gets new kidney, and patient does not need to be on dialysis, and it's less expensive than dialysis after the first year, and also um, not time consuming. It's done. Then you might have to uh, you, you might have to eat all your life the immunosuppressant, um, or you might be on all your life on immunosuppressant drugs after this transplant, but then you don't have to go to the dialysis 3 days a week, usually what is required. Now this is the next slide, and as I was mentioning earlier, the candidacy selection, how the candidates are selected, it is determined by a variety of medical and psychosocial factors, and it also depends on what the center is looking to. There is something called preemptive transplantation, which is transplantation before dialysis is required is done, and it's possible if the recipient is a living donor. So some transplant programs, they will exclude the patients who are morbidly obese or like just like they are non-compliant, or who continue to smoke despite giving them warnings or education about smoking cessations. Certain patients, particularly those with cardiac disease and diabetes, are considered at very high risk, and they must be carefully evaluated and then monitored closely if they get the transplantation. For a small number of patients who are approaching end-stage renal disease, preemptive transplantation is usually done at that time. That it means that the transplant done, or it is intended to be done, is there so that they can avoid the long-term effect of dialysis. Uh, but this is a very controversial topic, that whether the patient who's nearing end-stage renal disease should go for preemptive transplantation or not. Like, I am expecting I will go into transplantation, so how about I just go? No, I'm expecting I will go into end-stage renal disease and I will go into dialysis. So how about I just get the transplantation done preemptively? So that's what these patients do. But at the same time, why it's so controversial is because the patient is exposing himself earlier to the side effects of transplants, which can be the drugs, the rejection, and everything. So it's quite a controversial topic, but it is done. It is being done. It is there. Next, go to the next slide, which is slide 6. Um, This is a case study of a patient undergoing kidney transplantation, and she's a 49-year-old woman, history of type 1 diabetes. She recently received a diagnosis of CKD, and she's interested in pursuing preemptive kidney transplantation to avoid long-term effects of dialysis. So there can be a lot of questions which can be asked to this patient about, his medical history, his psychosocial history, so or his, whether she has been compliant or not. So there can be a lot of things will be considered if she goes for preemptive kidney transplantation. Let's go to the next slide. Now, when they are looking at the kidney transplantation, they will also look at if there are any indications to the transplantation. And if the patient has any chronic infection, any unresolved psychosocial disorders, any extensive vascular diseases, any chronic respiratory failure, or any untreated cardiac diseases, um, or they have any disseminated malignancies. Um, Disseminated malignancies are those malignancies which are metastatic, some cancers, which is like kind of spreading. Then all those patients, they cannot be a candidate for transplantation, kidney transplantation. At one time, it was said that patients who had a diagnosis of HIV were denied the opportunity for kidney transplantation. However, some transplantation centers that have included HIV infected patients in their center, they demonstrate graft and patient survival rates similar to those in the HIV negative population. So they are saying even if the patient is has HIV, their graft and patient survival rate is almost similar to those in the patient who don't have HIV. So there's no use, stopping them for not having this kidney transplantation. Next slide. On basis of evaluation, procedures may be required before transplantation. Coronary artery bypass or coronary angioplasty may be indicated for advanced coronary artery disease. So they can, on basis of evaluations, they can also be cholecystectomy. Cholecystectomy may be necessary for patients with a history of gallstones, biliary obstruction, or cholecystitis. So, also on rare occasions, bilateral nephrectomies may be necessary for patients with any refractory hypertension or any UTI or kidneys which are grossly so much large as a result of any polycystic kidney disease. So these are some of the procedures which can be done or which are required before transplantation if the doctor thinks that these problems need to be dealt first before they can go further with the transplantation. Next slide. Um, the kidney transplantation, they are trying to identify certain um, they do some kind of it's called histocompatibility studies, and they will look for an HLA antigen in both donor and the potential recipient. And when it matches, and they do some cross matching, if it matches, then they move further with the transplantation process. Now, the sources, it can be blood relatives or emotionally related living donors, some people who do it just for welfare, or they can be deceased donors with compatible blood type. Now, they can be also paired organ donation. Paired organ donation is the practice of matching biologically incompatible donor or recipient pairs to enable transplantation in both candidates with a well-matched organ. So both the donor and the recipient are giving each other uh, some help, you know. So the paired organ donation is the practice of matching biologically incompatible donor or recipient pairs to enable transplantation in both candidates with a well-matched organ. So that can be another way. Most of the times, faster is the blood relatives. So, and with blood relatives, it's also one thing that you cannot force the blood relative. So you cannot force the son to give his kidney for his dad if he doesn't want to. So that's also one of the things which doctors are careful of. Next slide. CL is married with two school-age children. She has very supportive extended family. Her husband, two sisters are tested to see if they are compatible match to donate. It is determined that CL's 39-year-old sister is a compatible donor. What information does CL's sister need about the pre-operative diagnostic studies and surgery? So, so live donor. So if there is a live donor, they can we would so it says what, and then in this slide it says what information does CL sister need about the pre-operative diagnostic studies and surgery. So we'll look at some next slides and we'll come to know. So if there is a live donor, there will be extensive multidisciplinary evaluations, psychological, financial evaluations. Cross matches are done at the time of evaluation about a week before the transplantation to ensure that no antibodies to the donor are present or that the antibody titer is below the allowed level. Advantages is with live donor is that it's better patient and graft survival rates, immediate organ availability, and its minimum cold time. And minimal cold time is that you know the you don't have to keep the kidney for preserve the kidney for a time. So when it's going to get transplanted. So as soon as it's available, it's taken out from the live donor, and then after a while, it's transplanted into the recipient's body. Let's go to the next slide, and ECG and chest X-ray will be done. A renal ultras, some renal ultrasound or renal arteriography or three-dimensional CT scanning can be performed to ensure that the blood vessels which are supplying each kidney are adequate and to ensure that there are no defects and to determine which kidney will be better to be removed. There will be 24-hour urine lab study, and they will look at the patient's creatinine clearance, total protein, CBC, chemistry and electrolytes profiles, hepatitis B and C, HIV, and also CMV testing will be done. A transplant psychologist or social worker will determine if the donor is emotionally stable and able to deal with the issues related to organ donation. So it's a um, complete evaluation and complete checkup of the person who is going to give the kidney. Okay, next slide. Kidney transplantation is donor sources. It says donor, but it's donor. So kidney transplantation donor sources. Deceased donor. When you have deceased cadaver, kidney donors are relatively healthy individuals, and they might have suffered an irreversible brain injury and are declared brain dead. Now the brain dead donor must have effective cardiovascular function and be supported on a ventilator to preserve the organs. Even if the donor carried a signed donor card, permission from the donor's legal next of kin is still requested after brain death is determined. The kidneys are removed and can be preserved for up to 72 hours, but most transplant surgeons prefer to transplant kidneys before the cold time, the time outside of the body when being transported from the deceased donor to the recipient reaches 24 hours. As I was mentioning, the cold time. So cold time is the preserving time, like the time out when the kidney was taken out of the outside of the body and it is being transported from the deceased donor to the recipient. Um, there's a hospital in South known as Loma Linda University, and they have this facility. They have a cold time system process in place where they can get the kidney from any hospital in Southern California or in somewhere in the Central California, and they have a helipad and they can get through plane or something easily. Sorry, they have a helipad, they can get through chopper or something easily the kidney, and they have this preserving unit where they keep the kidney and the patient is there, and it can be immediately and it can reach the recipient within 24 hours. So not all hospitals can do this. So when you have time and you want to go to Southern California, do go and visit Loma Linda University. It's a very good university, and they have a museum. They also have a museum there where they have kept all kind of specimens. Kids with three heads. Kids with baby born without brain. So it's an interesting place. Um, so the kidneys are removed and can be preserved for up to 72 hours, but most transplant surgeons prefer to transplant kidneys before the cold time is reaches 24 hours. So within 20, they will keep it within 24 hours. They think it's okay, but beyond 24 hours, they don't want to keep preserving the kidney. Okay, next, go to the next slide. Surgical procedure. Yes, of course, nephrectomy is performed by a urologist or transplant surgeon. The recipient is surgically prepared for the kidney transplantation in a nearby operating room. Uh, now the nephrectomy is performed by a neurologist or transplant surgeon, and it begins 1 or 2 hours before the recipient's surgery is started. So two operating rooms are there. So one where is the nephrectomy is being done, another where the recipient surgery is going to be done. Rib may need to be removed for adequate view, and it takes about 3 hours. The, the nephrectomy, and so it takes about 3 hours the whole process. The laparoscopic approach significantly it decreases the hospital stay, also the post-op pain, blood loss, and any length of time off the work. So laparoscopic donor nephrectomy is an alternative to the conventional nephrectomy, and the most common approach for live kidney procurement. So if there is a live kidney, the laparoscopic approach is done, uh, is opted for. And for these, because this is faster, that's why the number of people who are willing to donate a kidney has increased significantly, because instead of going the conventional pathway, conventional nephrectomy pathway, it can be done to a laparoscopic procedure, which is faster. Next slide. Kidney transplantation, surgical procedure in the slide continues, and the organ is the person who's receiving the organ is usually placed extraperitoneally in the iliac fossa, and the right iliac fossa is preferred for the placement. And there is a picture on the left. There is a surgical incision done for the renal transplantation. And the second picture, it shows surgical placement of transplanted kidney. So you see how the transplanted kidney is being placed where. So that's how the um, do you want the old kidney which is not functioning there? Some people just leave it there, or they might. So it can be left there as it is, and we just want the new kidney with new glomerulus to filter the blood. Next slide. So there is a plane going above my head, so you can maybe, I don't know if you can hear it. So let's go to the next slide. CL and her sister arrived together the morning of surgery. Her sister is taken to the OR and has a laparoscopic nephrectomy. CL is taken into the OR to begin preparing to receive the kidney. So let's go to the next slide. Now the kidney transplant recipient, before incision, the urinary catheter will be placed into the patient's bladder. Antibiotic solution will be instilled into the bladder. Bladder will be distended. Then the antibiotic solution will be instilled, so which will distend the bladder and it will decrease risk of infection. And the incision made will be of crescent shaped. Now, as soon as the kidney transplant recipient the transplantation is being done, rapid revascularization is critical. Donor artery is kind of connected to the recipient internal or external iliac artery, and then donor vein is kind of connected to the recipient external iliac vein. So all the system of kidney and its all the vascular network around it from the new kidney need to be connected to the patient's body. So the the blood flow, the arteries, the vein, everything should be brought up to the same level as it will be seen in a normal kidney functioning. Next is kidney transplant recipient. When all these connections have been completed, clamps are released and then the blood flow is re-established. Urine may begin to flow or some diuretic may be given. Surgery of transplantation usually takes 3 to 4 hours. I think the nephrectomy was also around 3 hours, the usual nephrectomy. The donor ureter in most cases is tunneled through the bladder submucosa before entering the bladder cavity and being sutured in place. So this is called uteroneocystostomy. Um, I'm not expecting you to memorize uteroneocystostomy, not this term. But yes, I would expect you to know, how the kidney transplant surgical procedure is done. What is uh, how the recipient receives the transplantation. Okay, let's go to the next slide. pre-op care, emotional and physical preparation, immunosuppressing drugs. Yes, we want to give immunosuppressing drugs because the new thing will be entering the body. ECG, chest X-ray, lab studies. Um, Now, if the patient is on peritoneal dialysis, they must empty the peritoneal cavity of all the dialysate solution. And why I'm telling this? Because dialysis may be required before surgery for any significant problems such as fluid overload or hyperkalemia. So before surgery for the transplantation, dialysis may be required if there has a problem of fluid overload or hypotassium. And if it's required and the patient is on peritoneal dialysis, they must empty the peritoneal cavity of all dialysate solution. The the vascular access extremity should be labeled dialysis access, no procedures to prevent use of the affected extremity for blood pressure measurement, blood drawing, or IV infusions. And I think you all have seen the vascular access for the dialysis on the patients who were on dialysis. Next slide. CL and her sister are transferred to a PCU, and she's resting comfortably after IV analgesics were administered. Her sister continues to complain of discomfort after 2 doses of analgesia. And then we'll see in the next slides how this patient problems can be, or this patient scenario can be, uh, dealt with. Post-op care, live door care is similar to that for any laparoscopic, open or laparoscopic nephrectomy, close monitoring of renal function, close monitoring of hematocrit. The donor who has had open nephrectomy mm, experiences greater pain than the donor who has had a laparoscopic procedure. So if the donor he had open nephrectomy conventional procedure, they will have more pain than the donor who is having a laparoscopic procedure. In general, all donors have more pain than the recipients do. So donors have more pain than the recipients. As in happening in CL's case, her sister is having more pain, although she went through laparoscopic procedures. Now, donors who have undergone an open surgical approach are they are ready to be discharged from the hospital in 4 or 5 days and can go back to work in 6 to 8 weeks. Um, Laparoscopic donors are able to discharge from the hospital in 2 to 4 days and can return to work in 4 to 6 weeks. So if it's laparoscopic procedure, they can go to back to work within 4 to 6 weeks. So if there was a laparoscopic donors, they can discharge from the hospital in 2 to 4 days and can return to work in 4 to 6 weeks. Donors who had gone through have the conventional nephrectomy procedure of surgery, they are ready to be discharged from the hospital in 4 or 5 days and can usually return to work in 6 to 8 weeks. Urine output in the post-op care may be as high as 1 liter per hour, but it will gradually decrease as the burn and the serum creatinine levels will try to come to the normal level. And fluid electrolyte balance is important, and large volumes of urine, as close as 1 liter per hour, can be there. Um, and large volumes of urine soon after transplanted kidney placed as a result of new kidneys' ability to filter burn, abundance of fluids during operation, and initial renal tubular dysfunction. So, in a nutshell, what it means is you can see large volumes of urine soon after transplanted kidney because the new kidney is still kind of taking gradually it will come into action and it will start filtering the blood and start taking care of the creatinine levels and everything will all those kidney labs will start becoming slowly normal. So that's why in the beginning you'll see high volume, but gradually as the new kidney comes into action, the volume will be balanced, the fluid volume will be balanced. Next slide. Now, post-op care recipient who got their urine output is replaced with fluids by ml, ml by ml hourly. And in this, they can also have some acute tubular necrosis. So and it's important to maintain the uh, catheter patency, the catheter patency of the catheter which is giving them fluids. CVP readings are essential for monitoring post-op fluid status. Um, any sudden decrease in urine output in the early post-op period is a cause of concern. It may be due to dehydration, rejection, a urine leak, or obstruction. So, a sudden decrease in urine output in the early post-op period should not be happening. It may be due to dehydration, rejection, a urine leak, or obstruction. Post-op teaching should include the prevention and treatment of rejection, infection, and complications of surgery, and the purpose and side effects of immunosuppression, which you can see after the transplantation. Adequately suppress the immune response. That's the first goal of kidney transplantation. Maintain sufficient immunity to prevent overwhelming infection. So, make sure the patient is not exposed to any, microorganisms or any uh, thing which can lead them to have infection. Um, there, there are different kind of rejections. Um, the first one is hyperacute. It's antibody mediated humoral rejection. It occurs minutes to hours after transplantation, and you can read in detail from your EG book. The second is acute rejections, which occurs days to months after transplantation, and chronic rejection process that occurs over months or years and is irreversible. Patients with chronic rejection should be put on the transplant list in the hope that they can undergo repeat transplantation before dialysis is required. Now, with our patient, the sister is getting discharged on the post-op day 3. CL is scheduled to be discharged 3 days later. And then, what is priority teaching needs for CL? So we just the first thing we want to teach CL is the early signs of rejection, the medication or incision care, and his activity. Because CL has diabetes, so her glucose metabolism will change after kidney function is restored. In addition, if she will be taking any steroids following the transplantation, these drugs will also increase her blood sugar. So she will need to monitor her blood glucose carefully and discuss the treatment completely with her nephrologist. Complications of transplant: infection, and most common infections observed in the first month are pneumonia, wound infections, IV line and drain infections, and UTI. Fungal infections: some of the common fungal infections are Candida. Uh, and they are not uncommon because patient is in immunosuppressed state. Fungal infections are difficult to treat and they are long treatment and often involve the administration of some nephrotoxic drugs. So that's another problem. Viral infections, CMV, one of the most common, uh, is one of the most common viral infection is CMV. Now, Epstein-Barr virus, herpes simplex, varicella zoster, polyomavirus. So, if a recipient has never had CMV and receives an organ from a donor with a history of CMV, then antiviral prophylaxis can be done, will be administered. So patient didn't have CMV, but the donor had CMV and he's developing those symptoms, then or he will develop those symptoms. So antiviral prophylaxis drugs can be given to the patient. And transplant recipients have increased incidence of atherosclerotic vascular disease. Immunosuppressions can work in hypertension, hyperlipidemia. Patients need to stick to antihypertensive regimen. The overall incidence of malignancy is greater in kidney transplant recipients than in the general population. The most common type of cancer after transplantations are some squamous cell carcinoma of the skin, Hodgkin's lymphoma, and Kaposi sarcoma. Other cancers for which patients are at risk include cancers of liver, stomach, anus, vulva, and penis. Um, Regular screening is important. Preventive care, protective clothing, and wear sunscreen. Yes, recurrence of original renal disease can happen. Then this can be another complication. Glomerular nephritis can happen. IgA nephropathy can happen. Diabetes mellitus can happen again, and there is something called focal segmental sclerosis that can happen too. Uh, Patients must be informed by the nephrologist before transplantation if they have a disease that is known to reoccur. Patient receives steroids after transplantation, and those steroids can lead to the complication as aseptic necrosis of the hips, knees, and other joints, peptic ulcer disease, glucose intolerance, and diabetes. Another steroid-related complications are dyslipidemia, cataracts, and increased incidence of infection and malignancies. Management: good body weight, acceptance of chronic disease, no infection, no edema, hematocrit, hemoglobin, and serum albumin levels in acceptable range. This is a quick question. 6 days after a kidney transplantation from a deceased donor, a patient develops a temperature of 101.2, tenderness at the transplant site, and oliguria. The nurse recognizes that these findings indicate what? So these findings indicate acute rejection, which is not uncommon and is usually reversible. Signs of acute kidney rejection include pain at the site of the transplant, flu-like symptoms, fever, weight changes, swelling, changes in heart rate, and reduction in urine output. So now you know if this question is there, definitely the sign of acute rejection is something which I might test you on. This is the end of the presentation.